guys, I'm Rachel and this is Karen, and our article is called Intensive versus Conventional Glucose Control in Critically Ill Patients. And this trial has a whole bunch of authors, so I hope that you're reading along with us and you can see exactly how many people were involved because it was such a large trial. It was international, multi-centered. I mean, it was huge. So there's a lot of different authors to this. And they range from physicians to RNs to analytical analysis people. So, moving on, this was published by the New England Journal of Medicine in 2009, volume 360, number 13. And our study was an international, non-blinded, parallel grouped, randomized trial. So, if that says anything, it's multi-continent and non-blinded, meaning that the doctors knew, and it was randomized because people were put in different groups.
Okay, so a little bit of background information about this trial. So hyperglycemia, it's a common issue in acutely ill patients, and severe hyperglycemia in these patients is associated with increased morbidity and mortality. So what this trial is wanting to know is they've looked at some other trials that were done to see how we should treat these acutely ill patients, whether we should have a tight control glucose on them or if we should have a more conventional glucose control on them. A tight glucose control, our trial considered to be between 81 to 108 milligrams per deciliter. A more conventional glucose control was anything less than 180 milligrams per deciliter. So the big question is how tight of the control. So like I said before, some of the previous studies that were done were just kind of inconclusive. They didn't really say that a tight glucose control or a conventional glucose control increases mortality. What they did show, though, is that a more intensive control of glucose in these patients led to more severe hypoglycemia, and that is related to an increase in mortality. So we're trying to figure out, or what these people are trying to figure out in the study is which method of treatment should we go with. Right now, the main course of treatment is to do the tight glucose control, but it is not widely accepted because of the inconclusive previous trials. So real quick, I'll talk to you about the population of this trial. So originally there was a lot of participants. It was like, I believe, over 40,000. They were each assessed for eligibility, and it ended up being that 6,104 participants were randomly assigned to this trial, and they were assigned to two groups. So we either had our group of intensive glucose control and we had our group of conventional glucose control group. So I said we had 6,104 participants. So in the intensive glucose control group, we had 3,054, and then in the conventional glucose control group, we had 3,050. So it was pretty evenly distributed. There were 42 hospitals involved. 38 of these were academic tertiary care hospitals, and then 4 of the hospitals were community hospitals. So these patients, so they required treatment within 24 hours of admission to the ICU, and in order to be incorporated into this, they had to have an expected stay of at least 3 days in the ICU.
So to piggyback off of what Karen's talking about in the population, so when you go to population, we're going to move on to the interventions now. So with the randomly assigned patients, they were actually randomly assigned by the clinicians that were treating them or by local study coordinators with the use of a minimization algorithm. So intensive glucose control group, blood glucose level of 81 to 108 milligrams per deciliter. So that's the intensive control group. So for the conventional glucose control group, you had the blood glucose level of 180 or less. I'm sorry, I'm getting really tongue-tied.
It is tongue-tied.
It's a lot of big words. So with that, you have insulin, and with both of these, they are being administered by insulin infusions. If the blood glucose level was 180, and discontinued if it dropped below 144. So that's what kind of knocks some people out, is if their blood glucose just like plummeted. And the trial intervention was discontinued once the patient was eating or was discharged from the ICU, but was resumed if the patient was readmitted to the ICU within 90 days, because this trial lasted for 90 days total. So it's a very long international multi-centered trial. So our endpoints. So we had primary, secondary, and tertiary. So for the primary endpoint for someone to be excluded from the trial is if death from any cause within 90 days after randomization. So if they passed away in the hospital or at home, they were excluded from the trial. Then secondary was survival time during the first 90 days, of course, that caused specific death, duration of mechanical ventilation, renal replacement therapy, and stays in the ICU in the hospital. And the tertiary endpoint was death from any cause within 28 days after randomization, place of death like the ICU, hospital, ward, or like at home, incident of new organ failure, positive blood culture, receipt of red cell blood transfusion, and the volume of the transfusion.
So a little bit about the statistics. So in our intensive group, we had 304 of our population that discontinued intervention. 44 of them were lost to follow-up, but 3,016 had data that was included into the analysis, and 3,010 of them had 90-day data. All the baseline criteria was pretty much even, so that was pretty even between the two groups. Our conventional group, we had 225 that were discontinued in the intervention. 38 of them were lost for follow-up, and 3,014 had data included in the analysis. 3,012 of them had 90-day data. Talk about our...
Okay, so in this parallel randomized multi-centered international comparison, we used intent to treat protocol, and the data was analyzed with unadjusted chi-square test. Secondary data analyzed used logistic regression, and other binary results were analyzed by Fisher's exact test. More deaths occurred in the intensive control group than the conventional control group by 829 in the intensive control group died, and 751 in the conventional. So there was actually a lot of deaths in the study. So the intent to harm ratio was pretty high, guys. So the odds ratio at 95% was 1.14, and the p-value was set at 0.02. The mortality rate difference was statistically significant. The intensive control group also experienced more incidences of severe hypoglycemia compared to the conventional group, and that was it was 206 patients experienced hypoglycemia compared to 15 in the conventional group. That's a big difference. And the odds ratio at 95% was 14.7, and the p-value was less than 0.001.
Okay, so our author's conclusion. So the authors conclude that the intensive glucose control led to more deaths than the conventional control. So the authors ended up correctly rejecting their original hypothesis, which was intensive glucose control had decreased mortality at 90 days. So the authors accurately documented their patients' inability to finish the trial in an unbiased manner, as the patients either died or withdrew consent. Some shortcomings to this study were that their inability to blind the physicians treating the patients, that was an issue. In addition, the patients were exclusively given enteral nutrition, in which they could have been undernourished, and the glucose administration by infusion could have caused more harm than benefit. And since the patients were likely malnourished, it could alter the results if the trial is repeated with increased nutrition administration. This could influence the results of the studies. So the length of time of this study could also be argued as being a factor of error. It was a lot longer compared to other times in the other trials. So just our feelings about this. So there are a couple of things in this trial. So one good thing was they did have this centralized database. So even though it was widespread and it was international, everybody recorded their data and it was translated into one database. One thing that they did also mention is that even though it did say less than 90% were on a life-sustaining treatment, so some type of life support, I kind of feel like if one of the main endpoints was death, then the people who are on life support should not have been able to continue in the trial, because we're looking at really mortality rates for these with their glucose control. And also one of the other factors was that one of the main causes of death had to do more with cardiovascular issues. This trial wasn't really set up to look at the effects of the glucose control on the cardiovascular system. So further studying would have to be done to see if the glucose control had an effect on the cardiovascular system, which caused the mortality. All the previous studies done before really showed that increased or very tight glucose control led to an increased happening of severe hypoglycemia, which is related to mortality. So because we had all these patients on this intensive glucose treatment, more of them, like Rachel said, I think odds were like 206 versus 15 had the severe hypoglycemia, so that would make sense that there would be a higher mortality rate in the tight glucose control group.
So, okay, I have some issues with this study. So I really don't, it's kind of bugging me because if y'all remember when we were in class, in the first statistics class that we took here, they mentioned that whenever the doctors aren't blinded, it can cause a lot of bias. So like it can cause doctors to treat a patient differently than the other because they kind of know the treatment. I mean, they don't technically know the outcome, but they could be more excited over this treatment versus that treatment. So it kind of bugs me that I didn't like that the physicians knew what group they were in, and I'm not okay with that. So I feel like that if this study was repeated, maybe they could blind the physicians, which it might be difficult because it is like an international parallel group. I mean, it's huge. It was a huge trial. And then, of course, I don't like what Karen mentioned. I don't like how some of the setup was with people that were on life support. I mean, that doesn't really prove anything because they were probably so critically ill that this treatment might have not made a difference. Like they might have died anyways. So I don't feel like those results would truly reflect the study, what the hypothesis was. So those were some of the weaknesses I thought that I saw in the trial. And I think that me and Karen kind of agreed on those. And then, of course, since they were critically ill, they were being given enteral nutrition. And we did come across the fact that the nutrition kind of varied a little bit between both groups. So we saw that difference. It wasn't a huge difference, but at the same time, it could have made a difference because, if your body is not given enough nutrition, then they might not be able to properly fight the disease state that they're in, or what we're trying to prove in this trial.
Yeah, because it was the intensive glucose control received slightly less calories because of that intense control. Mm-hmm. So maybe if they would have been able to have the same amount of nutrition as the conventional control, then maybe they wouldn't have had more the severe hypoglycemia outcomes.
Exactly. So those are definitely the weaknesses, and the authors. So if you're looking at your journal club thing right now, and it has the questions that you want to answer in this section, I'm kind of going off of. So I mean, they were able to identify the weaknesses, some of the weaknesses they did mention in there, and they did correctly reject the hypothesis. So I give them kudos for that. And they didn't really ignore the shortcomings of the study. They did mention that, by comparison, certain other studies were done in a shorter amount of time versus their 90-day study. And then some other studies weren't international, and then some, there were some differences in by comparison from other studies, but they didn't disregard that. So, like I said, I give them kudos for that. And the benefits of the treatment outweigh the costs and risks. For this treatment, there is a lot of mortality. Let's just admit that. And there's severe hypoglycemia. So for the sake of science, sure, like this is a great study. And I'm sure, actually, on my app or IPPES, one of the doctors quoted this study, which kind of wanted me to do this study because I want to see what they're talking about. So it is a good study, and residents do use it in practice. So for the sake of science, like this is a great study. But for the patients, that lost their lives, I wouldn't say that the benefits outweigh the risk, because really they just proved that this intensive control group of like really restricting your glucose can really mess up your body and be fatal. So I didn't agree with that. And so the outcomes for the patients, I think we can agree, was not very good.
Yeah, so I guess, and one thing that you can see from the other trials, how I said before that one of the issues were that they weren't very conclusive. One thing that is been decided is that severe hypoglycemia leads to an increase in mortality. You have more severe hypoglycemia in intense glucose controlled patients. So it might be a better idea to go ahead and stick with a more conventional glucose control in these critically ill patients.
Yeah. So last question that me and Karen are going to answer is, does this study investigate outcomes your patients care about, and should you change your opinion or practice based on the results of this study? If so, how? How would you change your practice?
Well, if the majority of people are using the tight glucose, which this study, I mean, it was done back in 2009. I would say if I had read this study back in 2009 and I was doing an intensive glucose control, I would have swapped to a more conventional glucose control in my patients based upon the severe hypoglycemia results.
Yeah. So I'm definitely in agreement with her. And so moving on, I think in our practice, if we ever become clinical pharmacists, we will definitely probably quote this article to residents. Yes, and definitely tell them if they haven't read this, they should read this before they do any kind of intensive control on glucose.
Hey guys, well, thanks for listening to us. Hope you liked it.